I'm now going to request Dr. Sapna Nangya, who's a senior consultant and lead head, neck, breast, and gynecology at the Apollo Proton Cancer Center at Chennai, Southeast Asia's first proton therapy facility. Dr. Nangia trained at the Armed Forces Medical College, Pune, and served the Army Medical Corps for 5 years. Following this, she trained at SGPGI Lucknow and has been in the field of oncology for more than 27 years. She has been an early adopter of advanced radiation techniques and was amongst the initiators of IMRT in India in 2002-3. Dr. Nangia has innovated an instrument to aid the delivery of breath hold radiation, a technique designed to reduce cardiac dose in breast cancer radiation. This instrument is under patent application. Recently, she has been an observer for proton therapy at the Miami Cancer Institute, Maryland, Proton Treatment Center, and Procure Proton Therapy Center at New Jersey, and is pioneering the development of proton therapy for head, neck, and breast cancer in this part of the world. She will speak to us today about the impact of technology in improving breast cancer outcomes.
Thank you very much, Dr. Sheila. Good evening and welcome, and thank you very much for joining us today and giving us this opportunity to discuss what is new in the treatment of breast cancer. And I will be touching upon the important role of technology in improving breast cancer outcomes. Let me just explain that, for initially about a few decades ago, or maybe even about a decade and a half ago, breast cancer was really not the most common cancer amongst Indian women. However, there has been a change in the profile of Indian women, and I'll touch upon that briefly slightly later. But what we see now is that in various cancer registries, in various parts of the country, be it Bangalore, Chennai, Delhi, breast cancer is in fact the most common cancer now. And it's only in the rural cancer registry. For example, this one in a place called Barshi in Maharashtra, is breast cancer the second most common. So breast cancer is, of course, an important area for all of us to be aware of, and it's by far, the more common malignancy, even in Delhi and in many other, as I mentioned, metropolitan cities. And why is that so? And that is because there is a change in the profile of the Indian woman. We know that one of the reasons why breast cancer happens is because of an uninterrupted exposure to estrogen. So when women marry later, have fewer children, breastfeed for shorter periods of time, there is an increased risk. And this almost parallels the development of a society. So as a society becomes more developed, these are the things that happen. And this is how we find that our breast cancer trends are mirroring that of the developed world, as there is a change in the fertility fertility patterns of women in India. But also more importantly is the fact that people are aware of the implications of a breast clump. They're more likely to visit a doctor if they notice a breast clump. People are more aware of the importance, for example, of screening, of mammography. And, these also have an important impact in our ability to detect cancer and, of course, in our ability to detect cancer in time. So, how has technology impacted? We know that drug development has impacted breast cancer treatment enormously. Drug development has led to the development of chemotherapy medicines, which make treatment more effective, reduce the possibility of the disease recurring. It has led to targeted treatment, so we can identify genetic markers in the cancer cell. We can direct therapy to the cancer cell, or to this target in the cancer cell. We have developed safer hormonal agents which make it easier for patients to have better treatment, which is also safer. But besides drug development, there has been a lot of development in technology. And what do we mean by technology? In the use of machines in the treatment of cancer. So what is the path of a cancer patient? There would be a mammography, there would be a fine needle aspiration, there would be some imaging, and then of course there would be surgery, then there may be chemotherapy and radiotherapy. So interestingly, technology has impacted all aspects of this paradigm, the way patients are treated. And what has that led to? That has led to, enormous reduction in the number of patients undergoing mastectomy. And this has been replaced by a larger number of patients undergoing chemotherapy or breast conservation. As Dr. Siddharth mentioned, this is of course not a new treatment. This is a treatment that has now been around for almost 4 decades, as he mentioned. And yet, one of the important requirements of that is being able to pick up the disease on time. And that is made possible if women, embrace the idea of screening. So what is it that screening helps us do? What is the impact of mammography? The impact of mammography is that fewer patients, as you can see, require mastectomy. More patients are likely to have breast conservation. Whenever patients are picked up on mammography, rather than picking up the lump themselves, we see that there is a change in the requirement or the take-up of lumpectomy rather than removal of the breast. They also are less likely to require adjuvant treatment. That means they are less likely to require treatment that is considered aggressive, so to speak. And interestingly, there is also an improvement in the chance of the disease not failing. So what is it? What is the technology telling us now? Where has technology leading us? The technology is actually leading us in the direction of making this business of detecting tumors even better. One of the things that has happened is the development of what is called digital breast tomosynthesis. Now, digital breast tomosynthesis is actually a very refined form of mammogram. It's a digital mammogram, which also basically it's like looking at the breast in layers. What does it allow us to do? It allows us to have a slightly better pickup rate. It has the chance of actually reducing what is called the recall rate, which means that when a patient is sent back and then called back because the mammogram has not been satisfactory. This is important in populations where there are, in countries where there are population-based screening programs. In India, of course, we know the screening program is really driven by patients or rather not a patient, but a normal person's desire to be screened. But in countries where screening has been done as a part of a population-based program, it has been found that the chances of an unsatisfactory mammogram are less. Similarly, there is a possibility that once we use digital breast tomosynthesis, we might actually be able to pick up higher grade tumors. Now, this is in fact one of the programs that has been adopted by the Apollo hospitals, wherein tomosynthesis is done as a part of a routine at present, and this allows us to offer this superior technology. Another very important technological advance is the development of an MR mammogram. It's not exactly a very new technology, but it's a very interesting technology. And what does it allow us to do? So what happens in a mammogram is that if somebody has very dense breasts, so this is fat, this black appearance is the appearance of fat, while this is the appearance of the breast when there is a lot of dense glandular tissue. What is this dense glandular tissue doing? It's making the mammogram opaque. It's not allowing the doctors to see what's happening inside. And because of that, there can be important lesions that are missed. Now, this interestingly is the mammogram, MR mammogram. So this is a mammogram that is performed in an MRI machine, a dedicated using a dedicated equipment. And this is allowing us to see inside all that glandular tissue and note that there is one abnormality here, which is not now in retrospect, when you look back, you can see that perhaps there's something happening in this glandular tissue. So this is what technology allows us to do. It allows us to, to make a gradual improvement in our ability to help the patient. What does MR mammogram help us? And the MR mammogram helps us in, for example, if there is a patient who has an underarm lymph node and we don't know where the primary is in the breast, it's not an obvious primary, then it can help us detect that. It can help us detect, as I already mentioned, a patient who has dense breasts. It also allows us to detect cancer in a recurrent situation. So it allows us to detect a recurrent breast cancer. Now, because of the patient having received radiotherapy, there may be fibrosis of the breast, which again renders the breast opaque to mammogram, and an MR mammogram may allow us to look with a little more clarity inside the breast. Similarly, if there is a patient who has a multifocal cancer, so we want to identify all the foci of cancer, this again becomes easier, more accurate when we have access to MR mammogram. Then we come to PET scan. Now, what is PET scan? PET scan is PET-CT is a dual imaging. So there is a CT scan, which tells us if there is any structural abnormality. And then there is the metabolic imaging. What is metabolic imaging? It is the ability to pick up a chemical signature. So for example, we are talking about here the cells which are avid for glucose. We want to pick up cells which are avid for glucose. So, we use that, we pick that up using a specific agent called FDG that has been labeled with a radioactive substance which can be picked up by a machine. So I'm of course oversimplifying this, but what I'm trying to tell you is that when we use this correlate of CT scan as well as PET scan, this is a technological advance that helps the patient. And how does it help the patient? Because it helps us identify accurately what is the stage of the disease, where is the disease present, in addition to what we can see clinically, in addition to what we can see with the conventional methods of imaging. And so it can lead to a change in treatment in as many as 15% of patients. It can lead to a change in staging in as many as nearly 50% of patients. As you can see here, we can identify, of course, very nicely, there is the tumor that is visible on a PET-CT and a tumor that is visible in the underarm as well as the breast. But you can see here that the structural information is really incomplete. But when we see it in correlation with the CT scan, suddenly we can see where this hotspot is lying. This area that is picking up the glucose very avidly is shining, but we can also see its exact location because now the PET and the CT are being fused or are being taken simultaneously, allowing us to get this information. Sometimes PET-CTs may help us pick up disease in many more sites that maybe this might be otherwise obvious. And as I mentioned, that would lead to a change in our treatment strategy. Now I come to one particular branch of treatment of breast cancer, which is entirely technology-based, which is radiotherapy. So now when we say about technology, so why scientists treat patients using drugs, and surgical sciences are based on the surgical skill of the training and the various aspects of surgery. This is a treatment which is based on a combination of skill and technology. So here we are using a machine to treat patients, but it's not the machine that is treating the patient, of course. It is the doctor, the skill of the doctor, the skill of the treating team that is treating the patient, but the technology is also very important. So this is how how radiotherapy is delivered. We first create a model of the body in the patient in a computer. We identify what area we are going to treat, and then we create a plan. So basically, it's a virtual plan being made in a computer, and we can actually replicate the anatomy of each patient and see how the radiation is going to interact with the patient, and how is the radiation going to interact with the tumor area, the tumor bearing area, as well as how it's going to interact with the area which is something that we don't wish to treat. So for example, in this patient, you can see this is the area that we wish to treat, but this is the heart. It is also, this is a cross section of the patient's body. The heart is also receiving radiation. In a breast cancer patient, that's quite important, because at this point of time, even with locally advanced breast cancer, we expect long-term survivors. In early breast cancer, we definitely expect long-term survivors. So we want very much that these long-term survivors should have a good quality of life, and they should not be impacted. Their quality of life, should not be impacted by the treatment that they have received. And towards that, in radiation therapy of breast cancer, there is a lot of emphasis on reducing the toxicity to the heart. Now, as I already mentioned, we normally think of radiation as a local treatment. We think that this is something that we need to direct to the local area. It will prevent the disease from coming back locally. And it is a fact. Giving radiation reduces a very dramatic, significant reduction in the risk of local recurrence. But interestingly, somebody had asked this in the Q&A section, radiotherapy also reduces the risk of developing metastatic disease. And radiotherapy also leads to better survival. How does this happen? When local recurrences don't happen, then distant metastases are fewer, and when distant metastases are fewer, the lifespan is better. So radiotherapy is not just a local treatment, it is also a systemic treatment. However, one of the consequences of this local treatment is that the patient may have an increased risk of developing a heart problem. What is this graph telling us? This graph is telling us that left-sided breast cancer patients have a smaller chance of remaining free of cardiac disease. Similarly, left-sided breast cancer patients have a smaller chance of remaining free of developing a myocardial infarction. This is most in diabetes. This reduction of, this chance of having a heart problem is higher in patients who have diabetes, in patients who have hypertension, in patients who had a stroke, in patients who are smokers, who are obese, who've had a heart problem in the past. The risk of having a heart problem is more in those patients. So as I mentioned, because we know that these are patients who will be long-term survivors, we want to look at ways and means of reducing the cardiotoxicity of these patients. One of the ways in which we do that is intensity modulated radiotherapy. And I have a little cartoon here to show you what that is. Body, tumor, older methods of radiation, which ended up treating normal tissue. The squiggly orange is representing normal tissue. However, modern methods of radiation, body, tumor, radiation, matching the shape of the tumor, and therefore sparing the normal tissue adjacent to that. So this is how we can actually shape the radiation around the tumor. If we are paying attention, we can shape the radiation, around the heart. This is one of the ways we can reduce the dose to the heart. This is again use of technology. Then we can use something called deep inspiratory breath hold. This is something that is being done, of course, at Inspiratory Apollo Hospital and my colleagues there. And this is something that I practiced while I was there till last year. So this is, we make the radiation patient take a deep breath, hold her breath in deep inspiratory breath hold, and then deliver the radiation only when the patient is holding her breath. What does that do? It separates the breast and the chest wall from the radiation, from the heart, and therefore reduces the chance of having a heart problem. And this is a video which I'll play, which will show you. So this is the patient now in the blue zone. The blue zone indicates that this is the area where she should hold her breath in this place. And you can see here what it says, beam enabled. And pay attention to the beam enabled. And as soon as she has stopped her, she has breathed out, the beam is on hold. This is called deep inspiratory breath hold, and this so far has been considered the standard of care for treating breast cancer in such a way that the heart dose can be reduced. And now there is a newer technique that we call proton therapy. This is a very new technique, and there are, it's still, you could say that it's available in very few places all over the world. And we are privileged that we are in a position to offer this to our patients. And for that, I need to explain to you what proton therapy is. Now, as you know, proton therapy is available in India only in Chennai. And in fact, in this part of the world, it's available only in Chennai. So in Southeast Asia or Middle East, so far it's not available. And let me first explain to you what proton therapy is. Proton therapy is basically a technique. The blue thing is representing X-rays or photons, the usual method of delivering radiation. This is the tumor. So a photon will actually pass through and through the tumor and also through and through a body. That is how we get X-ray. We stand in front of a plate, the X-ray goes through our body and then hits the plate. And that's how the image is captured. Similarly, when we get radiation, the radiation enters from one part of the body and exits into the other, out of the body on the contralateral side. Now, this is, of course, an oversimplification, and various radiation techniques allow us to limit the dose to the normal structures. With proton, we are taking this a step further. So, protons are not X-rays. Protons are positively charged particles. So, depending on their energy, they go and deposit all their energy at a place which depends on the amount of energy that they're carrying. So I will calculate the depth of the tumor, not me actually, the computer will calculate the depth of the tumor and then tell us this is the energy that we need. And then of course there is a bit of the tumor that has not been treated. So we take a lower energy and then we take another lower energy. But what I'd like you to note here is that nothing is going beyond. Nothing is going beyond the area that we have identified as the tumor. Now, together they will form what we call the spread out Bragg peak. This spread out Bragg peak allows us, in certain situations, to escalate the dose, in certain situations to spare the normal structures, and various other aspects. So, this is the proton center at Chennai. And this is in fact how the proton is made. The proton is made on site and then it is carried through a beam line and then comes and is delivered through these machines. So it's pretty, as you can see, pretty high tech. And this is where the patient lies down and then the radiation is delivered in this manner in a very controlled sort of setting. But I won't, I'll just summarize. And what is nice to know is that it can be summarized simply in this one slide. This is a very highly reformed form of radiation as it is being delivered in the present day. And what you can see here, the lower scale is a photon-based radiotherapy and the upper is a proton-based radiotherapy. And the difference is obvious. In proton-based radiotherapy, we are covering the breast area very nicely. This is a cross-section through the patient's body. This is the opposite breast. This is the affected breast. This is the opposite lung. This is the lung on the affected side. And this is the heart. And there are various chambers of the heart. This is the main vessel of the heart, which is called the left anterior descending. So what do we see here? We see that besides whatever is being given to the heart, some amount of radiation is going to the lungs, it is going to the heart, it is going to the contralateral breast. It's not a huge amount, but it is there. But in the heart, it is at a significant level. As much as 50% of the dose is going to the heart. When we come to proton, we find that the dose to the opposite breast, the dose to the opposite lung, ipsilateral lung, as well as the heart is negligible. In fact, even 10% of the dose is not going to the heart. And this is the difference. Is it going to impact? Is it going to impact the risk of cardiac disease? We don't know yet. We expect it to. And why do we say that? We say that because we have studies which tell us that every gray of dose that is given to the heart matters. We measure the dose to the heart in grays, and we know that every gray matters. Now, in certain people where the risk is high, such as in diabetics, obese patients, in smokers, in patients who've had, a heart problem, that incremental risk we do not wish to take. In very young people who are going to live very long, we don't want their coronary arteries to receive a dose. In due course of time, of course, there will be randomized trials. Randomized trials are considered a very good method of ascertaining whether a treatment is really achieving its goals or not. But when randomized trials results are going to take 10 years or so, it is considered acceptable to use good quality data, for example, from something what is called phase 2 trials, wherein we are actually observing a group of patients delivering treatment who have been delivered a certain treatment. And we see that that particular data is available for proton therapy. And therefore, I believe very strongly in due course of time, of course, this is going to become one of the very important methods of, a widely accepted method of delivering treatment once it becomes a little less expensive and more widely available. But till then, it is something that we need to be aware of, that this is, a wonderful place that technology has taken us, both for the groups that I have specified, but also for young patients. And why do I say young patients? Because in young patients, we know that radiation risk, we want to reduce the radiation risk because of its propensity, though small, but its propensity for causing second malignancies. And this is something that allows us to do that. And so, to sum it up, technology allows us to improve the outcomes. I have not covered biotechnology. Biotechnology is another area wherein we can do genetic studies, molecular biology, identify which are the patients who are going to benefit from chemotherapy. But it's an exciting journey, whether we talk about technology in its application in diagnosis, in its application in treatment, its application in chemotherapy. Thank you very much for your attention.
Thank you so much, ma'am. The entire talk centered so much on the importance of early diagnosis and accurate diagnosis, which would naturally lead to a significant improvement in the quality of life. I'm sure our viewers will have a lot of questions, which we will take.